Oh my god, I'm still recovering up for the weekend anyway. All right, so hi guys, welcome to episode 3 of Talking with Trev. I'm here with my amazing team here today. So this is Rob and Michael. We want to let you in a few conversations that we have around back pain. We know 1 in 6 Australians currently suffering with back pain. Up to 95% of Australians suffer with back pain at some stage in their life. It is an epidemic problem without doubt around the world. Back pain is now one of the leading causes of disability in terms of pain and quality of life as well. So we're going to have a chat with these guys, get some more information. Hopefully you guys can get some out of it. Likewise, if you enjoy the video, share it, like it. The more information we can get out, the better it's going to help everybody. All right, Rob, tell me about back pain. How often do you see it in practice?
Very common. I mean, it's one of the major things we treat here, and I don't know, it's just all the times, and it's sometimes overcomplicated, I think, by some people. It could be, I think it's just too complicated to be more simplified because it's a lot easier to fix than we think.
Yeah, so when you see back pain, when we start talking about back pain, what are the different types of things that you hear people put under the term back pain when they approach?
Well, it could be the low back itself, could be stuff related to the days of the sacro joint, plus also the referred pain in the back of the leg, into the thighs and legs as well.
Yeah, it's pretty broad, isn't it? There's a bit of a generalised category of back pain. Is it down low? Is it on the sides? Is it up higher? This concept of what back pain is pretty broad, isn't it?
I also think there's a big confusion between sciatica and any other nerve radiations. Everything's sciatica, right?
Everything's sciatica, yeah. What does sciatica actually mean? What is it?
Well, I suppose from a medical point of view, it's meant to be the nerve groupings that come out that innervate, that supply the nerve control of the legs, are being impinged and being irritated at some point and causing a referred pain. That's really the reason behind it. So it can be low back issue at the segmental level. It could be through, I suppose, muscle entrapment areas where the nerve pass.
Yeah, and this is a big thing. Like, most people don't understand that there's actually this nerve called the sciatic nerve that runs from your lower spine all the way down the back of your legs into your feet. It kind of supplies most of your legs and your feet and things like this. And this is where the term sciatica really comes from, is this nerve getting irritated. But we now know that sciatica isn't actually necessarily a neurological thing. There's muscular problems, there's pain referral patterns, there's a lot of different causes. I think there's like 14 or 15 different causes now that have been identified for what sciatica actually is, and there's a little bit of a misnomer that sciatica is involving just discs and things like this.
Yeah, it's a bit of an umbrella term for any leg pain that's going to be back.
Yeah, absolutely. All right, so what about the person who has back pain who has numbness in their legs and feet and things like this? What are we starting to think about with these type of patients?
More you look at the nerve, some kind of nerve issue, more segmentally at the spine. So look for issues in that more structural main area there, something being irritated or potentially damaged. So that's the first thing you want to eliminate and be able to control that environment first.
Yeah, fantastic. Yeah. All right, so what are the key things that you see that can irritate nerves at spinal level?
Oh, lots of stuff. I mean, you can go from. I find a lot with the spine at the spinal level. It's I like to picture the spine like a little bit like a tent, and all the strings that hold the poles up, the muscles, and when they're not holding right, we tend to cause like wedges within the disc, which can cause the disc to push the nerve or create an inflammatory response that irritates the nerve as well. But a lot of the time, you just get the function right of that spine, and then the pressure comes off. And
I find the interesting thing with that is that we think low back, and you always get people go around the back, but it's that balance between front and back.
Yeah,
you've got to look at the front stability that's got to come from it as well. So you look at both sides.
Just work around here.
Yeah, you can't look at the back, you're not going to resolve it. Or the treating where the pain is, as opposed to that structural stability being the driver for it.
Yeah, I mean, we've had this thing now, this whole concept of core strength. And there's this huge focus that's happened over probably the last decade. Like when I first got out in practice, it wasn't such a focus, but now it's a really big thing on, we've got to get the abdominals tight, we've got to get them stronger and the back muscles and all this kind of stuff. But there's kind of, I think, been a bit of a forgotten premise about the actual sling support mechanisms that are internal, the effect of the diaphragm that's supporting the core, the effect of the hip flexors, the iliacus that comes around and forms kind of like a sling to hold the lumbar spine up.
Pelvic floor.
Yeah, pelvic floor, all these type of things. And everyone's gotten so focused on the abdominals that we kind of forget these things, and a lot of people aren't getting the benefits from treatment that they should get, just simply because of the fact that the focus has been so distorted recently.
Yeah, I find that as well. Yeah, everyone's focusing on one little section, or it's always very kind of like the blinkers are on and looking at that one part where the pain is, rather than
Stepping back and looking at the full system, I think.
Yeah, I find that a lot. Yeah, even with the disc issue, it's like, yeah, look at my disc,
Yeah.
rather than what's affecting it. You know?
But that's another interesting thing. You find people come in with their X-rays. Oh, here's my X-ray. Here's my problem. But then on the other side, you have people coming in with perfect X-rays who have low back problems. So I think a lot of times that X-ray carries so much weight for them. Oh, there's the problem there, as opposed to, again, not looking at the system as a whole.
I mean, is there really a correlation between a nice looking spine and being healthy and no pain? Yeah.
Yeah, that's the whole concept. Yeah, what's more important, anatomy or function?
Yeah.
Yeah. And we sometimes, kind of as the whole evidence-based medicine things move forward over the last maybe 10, 15 years, that we've had this more push towards using scans to identify things. But for a lot of the times, the scans look the same whether you're dead or alive.
Yeah.
You can't tell any difference. So you'll be able to pick a dead person or a live person on a scan. So how much does it really tell us about function? You know what I mean? And the functionality of the way that things work really is a key marker and a key cornerstone to actually preventing injury and rectifying injury heading forward.
And that's probably go back on the exercise approach, is that people think, oh, as long as they're doing exercise, everything's going to be fine. But if that function's not there, exercise is not going to actually create, you're not going to get that stability. You're going to start compensating using other things to cover for where that functionality is lost. So you're not going to get the recovery, you're not going to get the strength and stability long term with it either.
You always create the compensation to become worse and worse.
Yeah,
so if you can't do it anymore, then it's really bad.
Yeah, I think it's a bit of an issue as well, because if you roll an ankle or you do a knee or something like that, you can visibly see what's wrong. Like you can see that it's inflamed, you can see the irritation there. It's not just pain, but you can visibly see, hey, this foot doesn't look like that foot.
Mm-hmm.
But when you start looking at the lower back, for a lot of people, they can't visibly see the fact that they're inflamed. Either because of the fact that they can't look at it because it's behind them, or otherwise the inflammation is so deep and so internalized that there's no visible sign that there's a problem there. So the net result is that we get pain and we kind of just push through it. Where if it was an ankle that you'd rolled, then basically we probably would put less effort on it. We may use crutches or support it or brace or something like that to give the ankle time to heal before we head forward, which doesn't really happen so much with low back injuries.
No, it's interesting, isn't it? Because you think with an ankle, you go down, you can feel around it, oh, this is sore. But the low back, you've got these little, the posterior aspect only, you can't feel through the front and what's happening to get that same feedback, and then the pain's just generalised. So you don't.
Yeah. So you just don't actually see the injury.
No.
And if you can't see it, well then we push through it. Yeah, they just don't believe it. Yeah. It's like, oh, there's nothing. I'll get through this.
Yeah.
But if it was that ankle that was twice the size, then
if it looks bad, we tend to go, oh, I'm worried about this now. Yeah. Rather than the other way around.
Yeah, and when we look at it from a low back perspective, when we've got so many different structures that are involved, and really we'll call it a bony prominence in terms of one column in the spine itself that supports the entire structure. From a bony perspective, there's a lot of moving parts that are all associated, which are very internalized, which we just never notice. And when they're dysfunctional, unless you're really seeing somebody who knows how to assess them properly, generally they just go unnoticed without anyone even realizing it.
Yeah, it's very easy to miss. I find it's very it looks fine. It's like, it's fine. I've heard a lot, like, people say, oh, you're pain. I don't know why you're in pain. Everything looks fine. Who knows what to do? That happens a lot too.
So tell me a little bit about your thoughts. How do we go the difference between strength versus function in terms of pain levels and problems within the spine?
Yeah, I think strength's one reason why it's an issue out of, like, let's say 10, you know what I mean? And that's why some people, I think, do exercise and it's everything for them and it helps so much. But then, you see, we've all had athletes that have pain and their tone's really strong and they got lots of muscle and then they're still sore in their backs. And a lot of the time, it's the reason why these muscles aren't firing properly that it's not supported. So you can train as much as you like, but until you get it working right, and that could be lots of causes,
I think there's sometimes missing with the strength side of things. It's a very functional activated movement, whereas a lot of the body's other stability is dynamic, where it has to happen reflexively, and that's maybe where it sometimes fails. That's where I think the function's more around that, where the function's there, that when something happens unexpected, you can balance and manage it, whereas you can do a controlled arm curl, but again, an example you use, if you lift up a brick, it's fine, but to actually catch a dropping brick is a very different neurological.
Well, how often do you think to turn on your glutes and your QLs and your obliques, to hold yourself up? You really don't.
Absolutely,
It happens by itself.
Let alone, something in a car park and a trolley moves and something like that.
You don't go, quickly turn on my core.
Now.
Yeah.
Just not in your car.
So a lot of these things are spinal reflex patterns that actually protect us as opposed to conscious thought processes. So when we're looking at guided motion from conscious thought process, like I'm going to stand up now, it's a very different mechanism than I'm falling, I need to stop myself, which is a lot more spinal mediated. When we have dysfunction in these reflexes, that's when we start getting
More likely to injury.
more likely to get injuries and things like this as
Or
well.
re-injury,
Yeah. Okay, so let's start talking about a couple of specific things here. Let's start talking about discs. We hear this thing about discs all the time, and we hear, we get referrals all the time from practitioners all over the place who've had patients who've unsuccessfully been treated for low back pain through a whole heap of different procedures, whether they be surgical or conventional, or conservative, I should say. So when we start looking at discs, from my experience, most of the patients that have been sent with so-called disc problems have had them on films, but when we actually, I've assessed them, they actually haven't had the disc as a primary problem. So tell me a little bit about how you see discs from a scan perspective versus a clinical perspective. So what's the actual rate? Like if you had a scan and were found to have some kind of disc issue, is that necessarily causing your back problems?
No, I don't see the correlation with it. Is that, again, you get so many people with scans, and I think we've all seen people come in with scans and their backs are horrendous, and you think, it's got a bad low back pain, and they don't. And as we mentioned before, people with good scan, you think, they're going to be okay, it's low back pain. So the correlation helps paint a picture, it's one component of it. But what you're looking for is more, are there neurological signs? Are you looking, do you have a loss of muscle control? Do you have change in your sensation in the leg? Is there any muscle atrophies that wasting your muscle showing that it's not functioning? That gives you more insight as real nerve issues. The other stuff's, but again, is that the disc, or is it more inflammatory? So, because what we're looking at is pressure on irritation to the nerve. Is it something physically, or is it just the chemical components around the nerve that's causing function loss? So then again, getting the structural function, getting the pressure off, allowing the function to return, and then the inflammation, those inflammatory processes go down, and then the symptoms will subside as well.
Well, I think that is a part of it. I think that this is they hurt when they're out properly. When you irritate it properly, it hurts, right? And they're in agony, and that's fine. But a lot of the time you see like an MRI or something, and it's a clear bulge, and people are like, they got a bulge at L5, and this happening at L2, and you're like, but then you look at those, and people aren't going, the pain's not there, it's all down here in my butt, or it's in my sacral leg joints, because they're causing that to bulge, even though the disc isn't necessarily causing the pain. It is just there, just like, I suppose, and even with arthritic change, everyone goes, you got arthritis, that's why you have pain. That's the other thing, I've changed the topic, but you know what I mean? Like, they go, my back's out, my back's bad, but it's an arthritic back, that's why it's bad. And after some correction again, it's stable, they're like, oh my gosh, it doesn't hurt anymore. And I think that doesn't have the biggest. I think people put a lot of weight on that.
Yeah, the scans have become the base of everything.
Yeah,
haven't they? And I know that there's been so many studies done on this topic of what's the current rate of these type of things, and most of the studies that I've read over the years say up to 80% of people without any form of back pain still have disc issues. And we now understand that most of the disc issues aren't necessarily the cause of their problem, but are just part of the degenerative process from long-standing poor function, as opposed to being an acute issue. And I think this is one of the big things that a lot of people forget as well, is that that just because you've got a change in anatomy doesn't necessarily mean that's the cause of your problem. And quite often, long-standing changes in function lead to the changes in anatomy, not the other way around.
That's exactly right.
It was a long time coming.
Function through the hip causing changes through here, then changing loading through the low back. So the low back comes as a compensation more function loss through hip flexors or whatever it might be.
Yeah, absolutely. Okay, all right. So what about when we start looking with people with pain going down the legs? What are some of the key things with this? So I know we've already spoken about the discs, and this is sort of one of the common reasons why pain goes down the legs and we get pain in the buttock and stuff like this. So what are some of the more other less common things that we see associated with pain down the legs, our sciatica, if you want to call
There's
it?
a lot of referral pains. I mean, what's the common one there? The sacroiliac joint referral down to the side of the hip or the front of the leg or into the knee, but and sometimes into the calf. And there's no neurological signs. It's just this ache that they get through there, and that's always referred to sciatica. But it's just the sacroiliac joint irritation. That's a big one that I see all the time.
What about you? What's your
So similar things, I think, like TFL, top pain or GT pain. So your sides on the hip, things kind of you complain on. But that's how it's low back related type stuff. We get more hip pelvic function.
Yeah.
And
the one that I love so much, and I spent so many years working through this, is the whole piriformis syndrome.
Mm-hmm.
Which is where we basically getting the piriformis, which is a small muscle that goes from the hip itself onto the sacrum and causes rotation of the leg, but also stabilizes the sacrum to some extent, from stopping it from dropping. When this thing gets wound up by people who have had mattresses that don't support them, they're laying on the couches sideways, not getting support, and these things are contracting like crazy through sacroiliac arthrogenic reflex patterns, which are turning them off, and these things get tight. And I think the figure is about a third of people have the sciatic nerve actually run through the piriformis. Yep. So the net result is as the piriformis tightens up, it just basically strangles that nerve and mimics a disc beautifully. So many people have all these disc symptoms, and you'd swear that it's a disc. The orthopedic tests are there, and then all of a sudden you get to the nitty-gritties of it and you realise it's just the damn muscle that's spasmed right up.
Yeah, that's why.
You change their posture and treat the area and the problem resolved.
Everyone does tend to change really fast after an adjustment.
Yeah, they're great, aren't they?
Yeah.
They're awesome. They're miracle disc cures.
Yeah, it's like one
Which happen all the time.
Yeah, absolutely.
And it's just bang, it's corrected.
Yeah.
Yeah, absolutely. Okay, well, let's get a little bit broader than this now. So we've been talking about this from a very biomechanical perspective. What about from a non-biomechanical perspective? What are some of the things that we see outside of biomechanics that may be triggers for back pain as well?
Like pure inflammation, for example.
Yeah.
I mean, you see a lot of complaints of, oh look, I'm okay once I get moving, but it's first thing in the morning it's the worst. Or when I get home from work, I'm trying to relax, and there's probably dysfunction there, but like the big aggravator there is just it's purely an inflammatory response where it's just accumulating in the area when they're resting, and I find just get that under control, and that can make a massive difference.
I think carbohydrate management, so just consuming the right blood sugars right out of the kilter is going to mess up the inflammatory across the body, which can then be specific to that area. That's big right now.
Yeah. There was a nice little study done going back a few years ago now where they looked at the ileocecal valve and using it as a correlation point as well. So the ileocecal valve being a small valve sits between your large and small intestine. You know the ones we're talking about. So the ileocecal valve sometimes spasms up with things like vagal dysfunction and a whole lot of other things, nutritional things. And what they found was like a high 90% correlation between valvular dysfunction or I should say changes in motor function as a result of ileocecal dysfunction as opposed to direct correction. But there was a really good correlation between the dysfunction of that valve and iliacus changes, which led to low back problems as well. So it can be quite broad. It doesn't necessarily need to be just biomechanical that drives this whole mechanism.
Well, that takes us back to what we were talking about. Why does the muscle become dysfunctional? It's not just exercising or it's specifically weak muscle. Loads of things, and that's a big one. That can cause it to not work the way it should and change that neurological pattern, and that's why it happens.
Right. So I want you guys to think about a couple of things for me quickly, and I want you to come up with 3 things that are the biggest things that you can do or get a patient to do that changes their back pain straight away.
Okay. Couches.
Yeah, couches is a big one. Yeah.
Just lifting techniques.
Lifting techniques.
Racing, walking up. Stuff.
And the third biggest one that I say is bedding. Yeah. So and you can test all these really simply. So the bedding side of things, generally it's a lack of support. So we've got videos on the Spinewise YouTube channel on that as well. So having a lack of support or too much support, so a mattress is too soft or too hard, So rather than being straight and being supported overnight, we're kind of bowed up or bowed down at the pelvis, which creates muscular contraction all night long. Couches are another great one.
Very similar, or similar to beds, right?
Same pattern, lack of support.
Or
The
weight
couches,
on it.
that's a really easy one to work out though.
Yeah.
So all you need to do is get a towel, fold it up, get a firm base, put it on top of the couch, sit on it, and see if it changes your back pain. If it changes your back pain, then there's a good chance that the couch being too soft is a cause for it. Yep. And what about lifting techniques? What's the big part of lifting techniques that you see the common problem? Because we all hear about lifting. Yeah, make sure you're lifting correctly, but what's the big part that seems to be driving for most people?
It's the extension, isn't it? So do you find it's the when you
I didn't understand that.
Yeah, it's the extensions for in most people's cases that seems to be driving it. Yeah, someone's phone's going off here now.
I mean, obviously making sure people don't lift and don't reach down to the side, so keep it sort of straight on.
Well, the twisting, right?
Yeah, twisting, so avoid the twisting movements.
Yeah.
So the extension is the big.
Yeah, well, the extension seems to affect the iliolumbar ligament somewhat. That's one that I've seen as well.
It's really safe.
That's really common. So when we get the sideways bending, I agree with you. When we're getting people sideways bending and rotating, this is the one that really damages the discs and just rips them to pieces.
Yeah.
Especially if you happen to be lifting and rotated and then sneeze or cough at the same time, you're in real strife. But yeah, and that's just the discs are really tightened up like crazy and bang, it's gone.
Pressures, right?
Yeah, but the most common one, which creates sort of day-to-day problems that I've seen, I know you've said the same thing, Rob, is when we lift up and then we get there, and then what we try and do is we get to this position and it's kind of too heavy, and we just lean back and extend to maintain it. Yeah, we kind of just rest on that lower spine. It creates like a pivot point in the lower spine, which tends to affect a lot of the ligaments in there and cause a lot of damage as well.
Another big one that affects that ligament is painters who paint ceilings because they're always extending backwards. Yeah.
Yep, above head. Yep.
Yeah.
And even people who are stocking shelves above head sometimes.
Yeah, as well.
Same thing.
Yeah.
New mums carrying the bub on the
There's
hip.
pop on the hip. That's the
Yeah, that's
Also
not
the
big
leaning
extension. Yeah, definitely big things. All right, so we had a few questions from some people. Have you got the questions there? Let's run through them. What were our questions that we had? A few people ask us.
Some of these are already covered, but
Yeah, let's
okay.
go.
What causes low back? I think we've gone through some.
Okay, so what are the biggest causes of low back pain that we see functionally? So the biggest cause we see functionally on a day-to-day basis, we're not talking about the people who are in potential risk for surgery or stuff like this, but day-to-day things, the biggest one would have to be the iliolumbar ligament dysfunction, which is a little ligament that sits between your L5 and your hip. And this thing basically regulates sacroiliac movements and spinal rotation as you walk, and spraining of that is right at the top of the list. That's probably the most common one that we see. The next would have to be muscular imbalances, functional muscular shifts, which would be QLs, piriformis, glute changes as well. And these are often lifestyle problems more than anything else.
Yeah.
And then after that, we start getting really broad, I think. We start looking at, hip flexor problems, diaphragm problems, strength problems, things like this that come way down the list. All right, what else we got?
Well, I think it covers this one. I don't do any heavy lifting. Why do I get low back pain?
All right, so low back pain, no heavy lifting. As we've shown, there is tons of different causes for it. Iliosacral valve dysfunction, one potential problem with lack of hip flexor support. Sounds weird, but even if you're not walking properly, this is a really big common problem of back pain. So as you're walking, we should be swinging and rotating the shoulders. How many people do you see that when they walk don't rotate their shoulders?
They just hang there pretty much.
Yeah, they just hang there and they just walk from their elbows rather than from their shoulders. So because they don't rotate their shoulders and they walk, they don't get spinal rotation, they get spinal movement, everything just jams up.
Well, yeah, it's a modern phenomenon because people spend so much time with their hand, hold their phones, they don't walk, they actually walk with the phone out in front of them.
Yeah, quite possible.
Yeah, no, it's interesting.
Yeah, very interesting thought. We might need to investigate that further, hey?
Another question we've got is, why does the low back pain come back? Injure it? I mean,
It's the same things. Habits, because there's some of the issues are habitual, it's like, I think that's why it comes back. It's like you go home, so a lot of people say, I've got to adjust, this was fantastic, great. Next morning I woke up with sore again. Something as simple as a mattress flip or maybe a new one in some cases could help a lot.
Yeah, we see this all the time, where people who have failed with other practitioners, it's generally because there are lifestyle factors that haven't been taken into account.
Yeah.
And you really need to be able to assess the biomechanics and the structure properly to identify those things. So if you're not looking at a true assessment to identify those issues, and it's very hard to work out whether those issues are coming back. And just doing simple strength programs, quite often they miss these type of things.
So I think sometimes that is the functional, some of the underpinnings haven't been solved properly. So that then the information comes down after they feel okay, but as soon as they get loaded, something untoward happens, and they're re-irritating it. So it's more of the functional to then resolve.
Yeah, absolutely. So, any other questions we got there?
People talking, why do I have low back pain when my X-rays are okay?
Yeah, I think we've covered that. So, remember, films and scans don't necessarily say about function. They do talk about anatomy and injury, but that doesn't necessarily correlate with injury patterns and with the way things are working as well. Rose, is there anything you want to know about back pain?
No.
No? Rose is going to hide and not get on film with us. Alright guys, thanks for joining us for another episode of Talking with Trev. Remember, share this, like it, comment below if you have any questions about back pain. We'll get back to you as soon as we possibly can. Have a fantastic week and we'll speak to you guys soon.